Good evening. My name is Dinno. I'm one of the co-owners of the Dinno Health Pharmacies, and it's an honor and privilege to have you guys with us tonight as we have one of our own doing a presentation, Dr. Silky Kaur. Silky is a clinical pharmacist that joined our pharmacies as a staff pharmacist back in 2021. She used to work at all across all locations, but now her home base is Keys Drug, our Newton location. She earned her Doctor of Pharmacy degree from Mass College of Pharmacy and completed a community-based postgraduate residency through Walgreens in partnership with MCPH University. Also, Dr. Kaur further expanded her expertise by obtaining an MBA in healthcare management from MCPHS University in 2022. So hopefully I'm not sure there's more degrees, but three is pretty good. Um, in addition to her clinical practice, Silky has been actively involved in professional leadership and advocacy. She has served on which was an honor and privilege to serve with her as well on the board of directors for the Mass Pharmacy Association since 2019, in various leadership capacities. She's very passionate about healthcare in general, especially pharmacy practice and advancing it, improving patient care, and supporting innovation with community-based healthcare. Today, our focus will be on GLP-1s in the treatment of diabetes, but also in the weight loss aspects as well that these medications are being utilized for. So I've spoken enough. Silky, the floor is all yours. Thank you for being on, Dr. Kaur. Go ahead.
Thank you, Saad. So thanks everybody for joining tonight. Really appreciate your time and hope you'll be able to take some things away from today's lecture. So, as Saad started to say, so we're going to be talking about understanding GLP-1 agonist medications and how they're helpful for weight loss and diabetes management. So just before getting started, I do want to make sure everybody knows this is really just for educational purposes. I'm by no means kind of giving you any medical advice. It's more for your information as there's a lot of buzz around this topic and so that you are able to understand and learn more and bring it to your healthcare providers if you have questions. Here's what the agenda is for tonight. So 4 points that I really want to cover. What GLP-1 agonist medications are and how they work in the body, how these medications are used for diabetes management and weight loss, common side effects, safety concerns, and who may or may not be a good candidate. And lastly, what to expect when starting therapy, including lifestyle changes and long-term use. So those are the big topics we want to cover today. So we'll jump right in. GLP, so you hear that acronym a lot. It stands for glucagon-like peptide 1, which is considered an incretin hormone in our bodies that's produced by the intestines and released after we eat food. So the key functions of that hormone are listed there so stimulating insulin release from the pancreas. I have an image on the right for more of our visual people, might be a little bit more helpful. The main are stimulating insulin release from the pancreas, especially when blood sugar levels are high, suppressing glucagon, which is another hormone that in turn releases blood sugar. So suppressing that will lower blood sugar. Slowing stomach emptying, which helps post-meal blood sugar spikes. And then increasing feelings of fullness, reducing appetite and food intake. So another hormone I just want to bring to your attention because the drugs we'll talk about later are in combination with this hormone GIP, which is glucose-dependent insulinotropic polypeptide. So that's a mouthful. So GIP is easier to say. It's another incretin hormone, just like GLP, released by a different set of intestinal cells in response to nutrient intake. It also enhances glucose-dependent insulin secretion. And anytime I say glucose, that's analogous to blood sugar. It helps protect against low blood sugar by increasing glucagon secretion. So very similar to GLP, but it complements GLP's role in appetite regulation and glucose control. It's also been identified as a key target for diabetes and weight loss management. So, in the name itself, GLP-1 receptor agonist, I thought it would be helpful to define exactly what receptor and agonist is. So, the picture on the right there, maybe you're getting flashbacks to biology about cells and things like that. But so, a receptor is basically considered as a cellular lock that only specific keys can fit into. So something that stimulates those receptor and it unlocks a particular action to produce a message into the bodies. An agonist is that key or a substance or a molecule that would bind to that receptor and cause that biological response. In drug development, that's usually to mimic something that's already happening in our body that we just may need assistance with. So on the right side there, you can see the cell membrane. There's a receptor, and you can see the GLP protein there. Once it attaches to the receptor, it goes on to go down a series of processes to then increase insulin secretion, decrease glucagon secretion, and then cause those effects that we'll talk about later. So, what exactly are these medications? So, I've already alluded to, they're for those two conditions, type 2 diabetes and weight loss. They work by mimicking those natural hormones that we discussed, and they copy the action of those hormones. Um, so when combining those, again, it can lead to improved blood sugar control, promoting greater weight loss, and overall supporting metabolic health. So they allow the person's body to respond better to food, control blood sugar, and feel full sooner, making them useful in these conditions. We'll get into a little depth later, but I did just want to bring out a table here about the drugs that are on the market that are in this class. So two of them are grayed out. They're technically off the market, not used really, just because more effective therapies have come out, the ones highlighted in blue. But I did want to keep them on the slide because their names still circulate, and I believe the generic, the first top one there, exenatide, still exists for certain indications. So this is a list here. They all kind of end in the same ending, indicating there are a GLP-1 agonist. And in the center there are the brand names that you probably hear circulating around, and then their indications on the right. So this is just to give you a snapshot. We'll kind of go into depth of it later. So let's get into how they're used. Before that, I want to give you a little background on diabetes and obesity prevalence in the US. So as of 2021, 11.6% of the US population has diabetes, per the National Diabetes Statistics Report. So that sounds like a small percentage, but that equates to 38.4 million people of all ages have diabetes. And those are people that are fully diagnosed with it. That doesn't include people that have prediabetes or who may not know that they have diabetes. From 2023, there's been data that 35% of adults have obesity, and that's been shown as a striking increase over just the past 10 years. And that can equate to at least 1 in 5 adults living with obesity in the country. So it's about, they're saying prevalence in diabetes is almost 4 times higher in adults with obesity versus 6.8% in normal weight adults. So meaning that both those conditions kind of play a role into each other. And that's why these drugs have kind of been of interest because they target both conditions. So, lastly, one shocking statistic is nearly 90% of adults with diabetes are overweight. So, another reason why these drugs are so hot topics these days. So getting into diabetes, so if I were to just talk about diabetes, I'd need a lot more time. So I'm just going to give you some bullet points on exactly what it is so we can understand how these drugs help the condition. It's a metabolic disorder characterized by high blood sugar levels. It can be divided into 4 categories generally. So type 1 diabetes, type 2 diabetes, gestational diabetes, which means the condition during pregnancy, diabetes caused by other medical conditions. So that could be autoimmune, cystic fibrosis, anything that disrupts insulin secretion and causing secondary diabetes would be part of that category. We'll focus on type 2 diabetes since that's what these drugs have been studied in and been able to show significant glucose reductions in. So that's where we'll just move on into talking about type 2 diabetes, insulin resistance. That's the main mechanism of what causes, or the pathophysiology that causes type 2 diabetes. So when we say insulin resistance, that's referring to our pancreas cells, pancreatic cells. They basically become or I'm sorry, our regular body becomes deaf to insulin that's coming out of the pancreas. So the insulin's there, our body's producing it, but there's some sort of disruption where our cells are not uptaking that insulin to reduce blood sugar in the body. It's also classified as something called beta cell dysfunction. So the pancreas tries to compensate by making more insulin, meaning there's more insulin or hormone in the body, but because it's not getting used appropriately, the pancreas then basically kind of slowly starts to burn out and gets exhausted. So then it leads to a result of insulin deficiency. So, type 2 diabetes is considered the most prevalent type out of the four categories that I mentioned, and it equates to 90% of all diabetes cases. Um, Again, for our visual people, just a quick snapshot here of what it looks like in the body when diabetes is an issue there. So type 2, so in people without diabetes, this is what a regular bloodstream looks like. There's a cell in the center there. The blocks labeled G is glucose or sugar from our food or anything that's created by our body to help us with energy later on. The I is considered insulin, so it's a lock and key method. We need insulin to bind to glucose to get into the cells. And in type 2 diabetes, so here's one that where there's high blood glucose, too little insulin is made, and because of that, the liver is increasing is in response to the pathophysiology is increasing too much glucose, and the cells are not intaking that glucose appropriately, thus not allowing us to have enough energy. And that's why people with diabetes, they end up getting diagnosed because they have symptoms of being very tired, very thirsty, very hungry, because their body is not being able to uptake that sugar as energy and so forth. So the GLP-1 medications, these agonists, so again, they help to boost insulin release by the pancreas. They reduce glucagon, which is a precursor to actual blood sugar. So if they reduce that, then that means blood sugar later down the line won't be produced as much, and therefore helping lower blood sugar overall. So where exactly do they fit into like the algorithm of care for diabetes management? So it's now recommended early on, especially for people who have other coexisting conditions like heart disease or are already overweight or obese. They can be used with or without metformin. So metformin is one of the primary drugs used in type 2 diabetes, and until now has always been the first line of therapy for treating that condition. But now they're saying that you don't need to wait. You can go on early on and prescribe one of these drugs along with the metformin if metformin alone is not enough. Or if for some reason somebody cannot take metformin, they can use these drugs right away. And they're preferred because, again, they lower blood sugar effectively. They also help with weight loss, and they have a low risk of causing low blood sugars. Um, and some also help to reduce the risk of heart-related events. So this is what I just discussed here. So the reason somebody may not be able to go on metformin is if they have some sort of allergy to metformin or they don't have adequate kidney function to clear some metformin. So this is where these drugs are helpful in place of that. Or if they are on it and it is not enough lowering percentage-wide of their blood sugar, then they can add this drug on as well. So that also strikes the question, why only in type 2 diabetes? So I just want to give a little background on type 1 diabetes. So they're not officially approved for use in this type, but that's because type 1 diabetes, person's pancreas is completely burnt out and they were born with this or it was later developed, but it's considered an autoimmune condition. And because of that, they're not able to produce any insulin. And that's why type 1 diabetes patients require actual insulin replacement. So GLP-1 receptor agonists are not insulin. They are a hormone that help to increase your own internal insulin. So that is why they're not fully approved, but they are being used off-label. I've been finding research saying that they are being used experimentally to help assist in other ways. Weight reduction overall is beneficial for anybody who has diabetes. It can prevent variability in the blood sugars, so too lows or too highs. Adding on a GLP-1 medication helps balance those things. And then it also allows maybe patients with type 1 diabetes to reduce doses of insulin. If you heard of or know of anybody who has type 1 diabetes, they have to use many units of insulin a day. So this is being studied to help reduce that volume and hopefully prevent side effects. So now that was a little bit about diabetes. Now I want to flip and talk about obesity. So basic mechanism of what's going on in there is that it's not just, somebody can't control how they eat. It's more than it involves a lot of biology, hormones, and eating behavior. So appetite and fullness are controlled by hormones in the brain. So that's important to understand because these medications work on those hormones. Some bodies signal more hunger and less fullness, and because of this back and forth, metabolism may slow over time, making weight loss harder for these individuals. And because of that, the body often defends a higher set point weight. Basically, their baseline is higher because of all this back and forth and unable to control those hormones. Weight regain is common in these individuals due to the biological responses, and because of that, these drugs are very helpful in targeting those complex hormonal signals. So where do these drugs stand in terms of treatment for obesity? It is now recommended as a long-term treatment option, so that means greater than 6 months. And it's used with lifestyle changes, not instead of them. So that doesn't mean, it's a magic bullet or anything. They do have to still continue diet and exercise. And that is kind of what they've been studied to be most effective. So it's indicated for chronic weight management. So there's specifics that you have to have a body mass index or BMI of over equal to or greater than 30, or a body mass index of 27 or greater with a health condition that may be caused due to that overweight. So it is part of a multimodal personalized treatment plan. These drugs are just one component alongside behavior change and supportive therapy. Evidence supports meaningful weight loss and improved metabolic outcomes. Clinical evidence has actually shown GLP-1 drugs lead to significant weight loss in many of those adults. So here's a summary. So this is how the GLP-1s help people with obesity. They help them feel full sooner. They reduce hunger and cravings. They support portion control and make lifestyle changes easier to maintain. And just some other potential benefits, why healthcare providers are really loving these drugs is because they not only help with blood sugar and reducing weight, but also because of those, it can help lower blood pressure, improve cholesterol, so that's what lipid disorders are, improving fatty liver disease, reducing your risk of heart and kidney disease, and delaying progression of diabetes-related nephropathy, which is a type of kidney disorder. So we'll bring it back to that table here. I can get into the specifics here. So the ones that we most often see now are liraglutide, which is Victoza or Saxenda. So there's two brand names there because they have different indications. One is for diabetes, one is for weight loss. Dulaglutide, or also known as Trulicity, is for type 2 diabetes. Semaglutide, which is probably the one that people have heard of the most, Ozempic, which is used for diabetes, and Wegovy, which is used for weight loss. There are oral options now in this drug called Rybelsus and the Wegovy pill, which actually just got released this month. So it's now on the market to help people who, might be afraid to do an injection or have trouble remembering the dosing of the injection and they prefer an oral option. Tirzepatide is the newest to the class in terms of ingredient. It's the dual GLP-1 and GIP medication that is called Mounjaro for diabetes and Zepbound for weight loss. So here I just kind of broke them up in a table too, so it makes it a little easier. And again, Byetta or Bydureon and Adlixin are no longer readily available on the market. They've been discontinued because of they're not as effective as these other options out there. So how dosing and administration, I'm just going to go over general because, I don't want to assume everybody here knows what they are or taking them or interested in them. But how these medications are started, the trick is to begin slow and the dose is gradually titrated over weeks. And that's to help the body acclimate to the medication, to help so if there are side effects, which in most cases there are, and we'll get into that, but it helps reduce the side effects coming on very abruptly and helps the patient get used to the body, used to the medication. So nausea is one of those very key top side effects that we see, and slow titration of the medications help that. How are they taken? Most of the ones that we talked about are injections given once weekly. Some older options are daily injections, but they go right under the skin. They're called subcutaneous injections. And then we just talked about the oral options, and those are daily pills. So, injections, again, are given under the skin, usually in the abdomen, thigh, or upper arm. Can be taken without regard to meals. As for the oral options, sorry, I forgot to mention on this last slide here, they have to be taken in a very specific set of instructions, usually like 4 ounces of water and then on an empty stomach, and you cannot eat anything for a half hour. So there's just a couple extra steps with those because they're peptides that have to break down, and usually you need an empty stomach to allow that process to start. And going more into so we said Rybelsus and Wegovy are the oral options in this class. Rybelsus is for diabetes, Wegovy is for obesity, and they use the same exact GLP hormone pathway to boost insulin release, reduce appetite, and increase fullness. The challenges, like I just mentioned, is that it is a daily dose. So, somebody who might not be a great historian for medications might not prefer this option. Especially early in the morning where you have to take it on an empty stomach with water only. That might pose as an issue for some people. Absorption is lower compared to injections. That's why the oral medications usually start at a higher dose versus the injectables. And it's more frequent. So those are the challenges. I did come across this diagram that a lot of people, might be questioning. It's the same ingredient in these two pills. So is it just rebranded? And I came across like there are key differences here. It's the same active ingredient. Doses may differ, and their FDA approval and what these particular whatever the particular drug company studied, it was for particular that indication. So right here, Wegovy has a higher daily dose versus the one for Rybelsus. And it's one is for weight, one is for blood sugar control, and the cost differs greatly too, and that's without insurance. So Wegovy is cheaper. That's kind of what is more enticing with that option these days for out-of-pocket options. And it's, let me see, new for, yeah, it's the same molecule, different pill, but different goals. So I just came across this diagram. I thought it was a good visual. Here's another picture of exactly where it is injected. So usually the abdomen, upper thigh, or upper arm. It's suggested to change injection sites each week. We usually advise patients in the actual packages themselves. There's check marks as to when the patient gives themselves the dose, and they can write exactly where they're giving it so they don't do it in the same spot the next week. So now go into common side effects, safety concerns, and who may or may not be a good candidate. So all these medications do carry a black box warning, basically a big no for anybody who has a personal or family history of medullary thyroid cancer or MTC. And anybody who has MEN2, which is multiple endocrine neoplasia syndrome type 2. So in animal studies, these drugs were showing that they exacerbate these thyroid cells. GLP-1 has been discovered to be on thyroid cells for rodents. That's where these drugs were studied, and because it GLP triggers these cells, it causes inflammation and thus cause these conditions. So that's why they have a big black box warning on these drugs that if anybody has these conditions or even has a family history of them, it is not recommended or contraindicated for them to be on these drugs. And I do want to know it hasn't been seen in human studies, because of that preliminary study data, they just out of an abundance of caution put this black box warning on there. And of course, if there's a known serious allergy to any of the components in the drugs, that would be a big no also. So, a few things to consider being cautious with, or they're not recommended in, is anybody who may have a history of pancreatitis. So, pancreatitis is inflammation of the pancreas, and that could be due to any other conditions that they're having that's causing, disruption in the way they release insulin and inflammation in their pancreas. So, because these drugs target a hormone out of the pancreas, it's not recommended to be used in that condition. It could worsen conditions. Anybody with severe gastrointestinal disease, such as anything gastroparesis. So we talked about in the beginning that these drugs slow gastric emptying, so they slow everything down in the gut. And if somebody already is having gut issues, we don't want to exacerbate those problems by adding a drug that is slowing down processes. And it's also not recommended in pregnancy or breastfeeding. And I'll go into depth on that on the next slide. Type 1 diabetes, we kind of already discussed. It's not recommended because it's not considered insulin replacement. So, GLP-1s in pregnancy, I did want to bring it up because a lot of younger people are interested in these drugs because of their weight loss capabilities. And so that means people who, younger aged women who can get pregnant. So I just wanted, it is considered category C, which is indicated as not safe for people with being on a GLP-1 agonist because it can cause fetal harm. So that was again detected in animal studies, not seen long enough in humans yet because they've already just put a warning out there because it was noticed early on. If you can become pregnant, the recommendation is to use effective and reliable birth control while being on these meds. And if you do become pregnant while taking it, then the recommendation is to talk to your healthcare provider to slowly taper off of these medications. Continuing warnings and precautions. So common and expected side effects are nausea, vomiting, diarrhea, and constipation. So these are those gastrointestinal side effects, which are the most common. And symptoms usually tend to be mild or moderate, and that's due to the slow titration of the medications. So the very first doses of these medicines are typically not considered therapeutic, meaning they're not actually created to lower the blood sugar levels or cause weight loss right away. It's more just to get used to the side effects and acclimate the body. Serious or less common side effects are the pancreatitis, which is inflammation of the pancreas, gallbladder disease, and kidney problems, especially if the patient is dehydrated. Blood sugar considerations, it's a low risk of low blood sugar when used alone, and that's why they're very favorable for diabetes. And the risk increases if combined with insulin or a drug class called sulfonylurea is used in diabetes. Digestive effects. So again, they can slow stomach emptying. So use in caution with people with severe stomach or intestinal conditions because we don't want to make those conditions worse. Other considerations to think about are these drugs affect absorption of other medications. So if you're someone who is on other drugs, because of the mechanism of the GLP-1 drugs, they can affect how other drugs are broken down. So how they're absorbed, it can slow down their excretion or elimination from the body, keeping them in the body longer, and then causing side effects due to that, or not causing an action from your other medications fast enough, so they might not be as effective at a dose you were taking if you were not on these medicines. And vision changes is another consideration, especially in people with diabetes, because these drugs are so effective and they drop blood sugar quickly, is that it can cause vision changes. And if that happens, then that does need to be brought to the doctor's attention. Weight regain can occur if the medication is stopped. So that's one downside, and we'll get more into that later also. So here's from the actual package inserts of the drugs themselves. You'd recommended to call the provider if you have any of these listed issues. So severe or ongoing nausea or vomiting, severe stomach or abdominal pain, persistent vomiting or diarrhea, and signs of gallbladder problems, symptoms of very low blood sugar, vision changes, and any allergic reaction symptoms. An emergency would be considered as unexplainable severe abdominal pain with vomiting, trouble breathing or swelling of the throat, signs of severe hydration. And of course, early communication helps prevent complications. So as soon as these things are noticed, it's best to get emergent care. So to just summarize it, if somebody was considering to go on one of these medications, they can use this yes or no checklist here to see if you would even qualify being considered to go on. So the first three are complete no, contraindications about the medullary thyroid cancer, pregnancy, and then the bottom 4 points are more about having other conditions that may not be beneficial while being on these drugs. So I did want to talk about, what helps with some of those common side effects. Us as pharmacists, we're asked these questions all the time. So I did want to just give a nice breakdown of each side effect that's very common and what can help limit or prevent those side effects. So for nausea, eating smaller, more frequent meals, avoiding greasy or heavy foods, eating slowly and stopping when full, not overdoing it, and taking your medication exactly as prescribed. For vomiting, if that does occur, it's important to stay hydrated, get your electrolytes in, take small sips of fluids. Whole dose increases if the vomiting is so much that it's not stopping. So, trying to get used to one dose before moving on to the next is important. For diarrhea, increasing fluids to prevent dehydration, because being on these drugs and getting dehydrated enough to a point can cause kidney issues, and we don't want that to happen. So staying hydrated is important. And choosing bland foods, so you can think of like the brat diet, so bread, rice, applesauce, toast, and avoid alcohol and high fat foods for that time being. Constipation, increasing fiber gradually, drink plenty of water and stay physically active. Decreased appetite, because the amount of food going in the system is decreasing due to the effect of these drugs. It's important to make sure the meals that you are eating or the snacks you're eating are nutrient rich, so especially protein. So making sure you're getting most of your calories from that, and avoiding skipping meals completely because that can affect blood sugar levels and in turn affect weight gain or weight loss. Fatigue or headache, maintaining hydration again, ensuring adequate calorie intake and monitoring blood sugars if you do have diabetes. So, again, going off of the FDA labeling, who is a good candidate? Anybody with type 2 diabetes and obesity, being overweight or obese with a BMI from 27 to 30, and having a weight-related condition. People who have not achieved goals with lifestyle changes alone. So they've exhausted other options, diet, exercise, trying to do it naturally. Then adding a GLP-1 agonist might be of consideration. And individuals who are willing to use medications long term, because unfortunately, at the moment, the data says that weight is lost and kept off if you stay on these medications, and you keep up with lifestyle changes, also diet and exercise. And then if you do get off, unfortunately, that weight can come back because those hormones go into that imbalance again, prior to when, before, like they were before starting the drug. And then those, of course, who are able to participate in regular follow-up because of, the risks that come with these medications. Lastly, we'll talk about what to expect when starting therapy if one does decide to start therapy, including lifestyle changes and long-term use. So again, it's really emphasized that starting at a lower dose is important. Even if it's going to be beneficial or not, it's more for side effect toleration. Slow increases of those doses help reduce the side effects. Early changes include feeling full sooner, decreased appetite, mild stomach side effects, weight and blood sugar improve over a long period of time. So a percentage is dropped after a certain amount of time. Lifestyle still matters, so that means working best with balanced meals, adequate protein, hydration, regular movement. Medication is a tool, not a replacement. I think that's the myth. A lot of people are under the misconception that, just adding this onto a regular lifestyle would be beneficial. It has to be in conjunction with balanced meals and physical activity. Long-term use and follow-up, it's often used long-term. Stopping may lead to weight regain, like I just mentioned, and high blood sugars, and regular follow-ups are needed to ensure safety and success. Um, when you're officially on these medications, what do doctors actually monitor? Doctors and the people on it, the patients themselves. So I made a couple columns of diabetes, what they look for, and what people using it for weight loss look for. So in diabetes, blood sugar control is the number one indicator if something is working. So an A1C, which is the blood test done to show your blood sugar range over a period of 3 months. And of course, blood sugar readings at home are indicators of if these drugs are working. Weight and vital signs, of course, weight changes, changes in blood pressure. Medication safety wise, looking at low blood sugar risk is also monitored. It's definitely higher when you're on other medications for diabetes. The side effects, as we talked about, and then, of course, follow up for the medication adjustments, because as dose goes up, that also comes with more risk of side effects. For weight management, of course, it's the number on the scale, so weight trends over time, the waist circumference, as well as medication tolerance, so how suppressed the appetite is, and then the side effects. Safety monitoring is more for gallbladder because doses are higher for GLP-1 medications and weight loss. So the side effects extend out to the different organs also. So the gallbladder, your pancreas, and of course those black box warnings, the thyroid-related symptoms. Follow-up, focus on dose tolerance again, and lifestyle progress check-ins. So overall, both of them are looking at nutrition and hydration, physical activity, adherence to the medications, and overall well-being. So I did put a few questions on the next couple slides that I've come across. So are these medications new? So not really. GLP-1 medications have been being used for type 2 diabetes for over 15 years. Weight loss indications are newer. That's why we're hearing more about them. But the drug class itself is well studied. Do we know long-term risks? I'll say this is probably like the most common question I hear because they're worried about getting off of the medication or staying on it for it to work for weight loss, they have to stay on it long term. Large studies and real world use include millions of patients. So overall, they have a strong safety profile, but ongoing research continues to monitor long term use. So basically, the answer is we don't know what happens with long term use just yet, at least for weight loss. There is 15 years of data for diabetes, but again, it's still being studied. Can these drugs cause vitamin deficiencies? They don't directly cause deficiencies. It's as a secondary effect to eating less or having your appetite decrease overall. They include nutritions that you have to look out for are the protein, vitamin B12, iron, and vitamin D. A lot of these, which you get through diet. And so if your diet is decreased, naturally these vitamins would be decreased. So it's important to make sure these vitamins are being and supplements are being monitored for you as well. Do you need to stop these medications before surgical procedures? The way these meds work is that they slow stomach emptying. So because of that, if someone is going under anesthesia, that might slow the elimination of that anesthesia. So the effect can be increased or it leaves the body later. So they came across the recommendation that usually, typically before surgical procedures, these medications are temporarily stopped. But you always have to run this by, of course, the full healthcare team. What long-term issues are being monitored? So, digestive side effects, of course, that's the main thing. Gallbladder problems, especially again if it's a quick weight drop, muscle loss if nutrition is inadequate, weight regain if the medication is stopped. And what about cancer or serious risks? So we talked about thyroid cancer risk seen in animal studies. It's not confirmed in humans, but out of an abundance of caution, anybody with a history of this cancer should not be taking these drugs. No clear increased cancer risk seen in large human studies so far. So for the right patient, benefits often outweigh risks, and with proper monitoring and follow-up, you can find success. So the take-home points for today is that GLP-1 medications are tools, they're not cures. Best results come from medication and healthy habits. Treatment decisions are individualized. So again, whatever I presented here today was just for educational purposes. It wasn't medical advice. These medications are not for everyone, and working with your healthcare team is very important to get your questions answered, see if this is the right drug for you. And of course, including your pharmacist, we can help we're in community settings. We can help with any questions you have about administration, side effects, if it's the right option for you, and so on. So thank you everybody for listening. I hope that wasn't too painful listening to you for that long. But I'll take any questions if anybody
Silky,
does have.
Silky, there are thank you. Great job,
Yes,
by the way. Great
thank you.
information. A lot of yeah, it's a lot of information, but very good information. So there's a question is I'm curious when someone wants to taper off, how long does that usually take? And I think that's more of a, that's more depending on the person and how long you've been on
Right.
it. But if you could answer that question, that would be
Yeah, it
great.
depends on what it's being used for, what dose they're already on and how, but I don't believe there's a specific tapering schedule. It would have to be discussed with the doctor, but abruptly discontinuing these drugs is not ideal because then it can cause those side effects as like a rebound side effects. So,
Okay. Yeah, I mean, I've heard that, as you said, alluded to, that, you stop these for the most part, if you're not keeping up with exercise and diet change, et cetera, that the weight will be regained.
right.
And that's one sort of an indication is as you decrease those
Yeah.
doses, if you're gaining weight, then you know that, you need to go a little slower.
Right, yep.
Um,
Yep, because these medications affect those hormonal pathways that we talked about. When that drug is not there anymore, it's pulled from the system. Unfortunately, those hormones come back to how they were originally, the imbalance. So, because of that, then unfortunately they go back into those different eating patterns and are not able to reach satiety quick enough, and then it causes weight regain.
Got it. Thank you so much. Also, if insurance doesn't cover this without diabetes, is appealing that ever successful? If not, what do the pills cost out of pocket?
So I think that manufacturers have their own programs to offer these to people out of pocket. But as far as insurance, some people might not cover it right away, but it might be covered with doctor's approval. So having the doctors do some paperwork for the insurance, really listing if it's for a proper FDA approved indication. The couple drugs that have, dual brand names, so like the Wegovy and Ozempic or the Mounjaro and Zepbound. Unfortunately, sometimes doctors prescribe the wrong one for the wrong indication. So that's usually just a quick fix. They can, and usually at the pharmacy, we're able to help the doctors with that to prescribe the right one. I actually did that today for someone. They prescribed something. So it's important that the right drug is picked for the right indication. And like I said, yeah, the drug manufacturers actually have a lot of programs to assist with out-of-pocket costs. But any of these other websites, I really can't speak to if they offer any benefits.
Thank you.
Mhm.
Um, you haven't mentioned muscle loss, which I have read is a risk. That's a great question, and maybe in the same aspect, maybe you should hit on, how important protein, intake is important when you're on these medications as well.
I was going to
Yeah,
mention that.
Yep. Oh, yes. Yeah, so I think muscle loss, I maybe, sorry, I went over it very quickly. It was listed on one of the slides there, but muscle like atrophy and things like that. And it's exactly that. It's due to diet decreasing. So that's why it is important that any nutrient that is being taken in, either a snack or a meals or protein rich, because those are the building blocks to muscles. So naturally, this is all like a domino effect. So naturally, if we're not intaking adequate diet, then that over a long-term period which is how these drugs work, since you do have to stay on them for a long time for them to work. It's important to set up a balanced diet while on them. So that's where the muscle loss comes from.
And exercise as well will, of course.
Exercise, obviously, yeah, of course, exercise too.
Sorry, you might have missed my question. Have all the drugs discussed been thoroughly through a clinical trials for the indication given?
Yes, for them to come to the market. So everything that I discussed was exactly out of the FDA labeling. So for them to come to the market, they have undergone robust clinical studies. And like I said, the diabetes related ones, they've been on the market for over 15 years. The data from those has also been used into the studies for the weight loss drugs because they are the same molecules. They were then just restudied at different doses.
And of course, they've been studied as we speak for other indications in the
Yeah, for the
future.
long-term risk that we talked about,
Yeah.
unfortunately, there's not enough data out there yet. So that's
Right. But I mean, the class itself is being studied for a lot of other
yes,
indications that
yes,
we
other
will hear about in the future.
yes.
Um, so we discussed how important it is to do protein and exercise and while you're on these medications and it's been very helpful to a lot of people.
Yep.
Um, and from a diabetes aspect and from a weight loss aspect. So, it's a good class of drugs. It's just conversation with providers is always helpful and just be careful where you buy them from, et cetera, because not everything is the same. So I saw a woman who looked as if her face was melting. Is that called Wegovy face? That's a great question.
I
So
was just about to mention that. I was
yeah,
just
we
about
we
to
get
say
that a
that.
lot,
Yeah.
Deb. But go ahead if you can answer that.
Sorry, what was the question? I missed the first
About
part.
Wegovy face, she says I saw a woman who looked as if her face was melting. Is that what it's called,
Oh,
the Wegovy face?
yeah, because of the like robust response by the body and losing the weight. Actually, weight gets lost from the face first, so that's probably why it's actually all like gravity that is a fact that weight gets mostly taken away from the face first and other parts of the body. So because of that fast weight loss, that's probably why you can see the way that presents on the face.
Okay. Any other questions?
If there's no more right now, we did have a few questions submitted before the lecture, so I can go over those if
Please.
we could talk about those. So someone asked, can I still use weight loss medication if my PCP says I don't need it and won't approve it? So the right answer is, unfortunately, these drugs need a prescription. You need oversight from a healthcare provider. I would question why your provider doesn't think it's a good idea. Obviously making sure you fit within that FDA approved indication that's why you would be prescribed something like that. So there are four specific medical criteria. So unfortunately, you do have to fall into one of those to be able to be prescribed one of these. Um, so if you disagree with, your PCP, you could get a second opinion. I would recommend that if you can talk to somebody else, maybe a different provider, and get a second opinion. That would probably be my advice. Because there are safety risks that come with these medications, so you don't want to abruptly make decisions. So the next question they asked was, can I use a small or mini dose just to lose a few pounds? So these medications aren't approved or studied for short-term use. Again, as I kept mentioning, the effects have been seen if it's on hand for long term. So GLP-1s are designed for chronic disease management. So that's where the indications for type 2 diabetes come up and obesity with multiple conditions. They're studied at specific doses and titration schedules. So a mini dose, nobody really knows what that's defined as. If there was anything prescribed under a FDA approved dose, that would be considered experimental or used off label. So micro dosing has limited, safety and data information. So it still also can cause side effects. So someone wanting to lose a few pounds, any provider would just say, obviously, just try lifestyle changing first. And if that fails, and if you fall in the criteria of the prescribing of these drugs, then that would be an option. Last question was, are there dangers to stopping the medication once you are done losing weight? So, stopping the medication, just generally speaking, would be safe. It's not going to be detrimental. The worst part would be the weight regain, which is why somebody would have started those medicines. But it's not technically a risk to stop these medicines. GLP, let's see, yeah, so again, so it's not like other drugs where it's causing like withdrawal or has a dependence effect or something like that. It can be stopped as long as that's carefully planned with the healthcare provider. And you have strategies in place to maintain that weight loss for now, at least.
But to answer all those questions, and the audience as well, it's just about, you get on these medications, and if you want to stop, you just got to maintain the exercise, the dieting,
Yes, right. You can't forget those other habits. And unfortunately, you'll
correct.
have to train your brain about like, the eating habits and things like that.
Perfect. I think we're at 55 minutes in. Well done, Dr. Kaur. This
Thank you.
this meeting is or this presentation is being recorded, so we'll put it on our YouTube channel soon. So if there's no further questions, I'd like to give you guys back a few minutes of your life to go back to your families. And
Yeah,
Dr. Kaur, thank you so
yeah.
much. A great job.
Thank
Thank you
And
very
you.
thank you to
much.
our
Thank
Thank
audience
you for
you.
the opportunity. I did want to just pitch
Thank you.
ourselves. We're five pharmacies full of wonderful pharmacists who have so much knowledge. So if you guys ever have any questions, feel free to call us. Or I myself, like Sad mentioned, I'm at the Newton location, so you can come by to say hello or call or whatever you
Absolutely.
like.
Thank you so much.
Thank you.
Appreciate it.
Thank you. Thanks,
Thank
Appreciate you.
you. Take
everybody.
care. Have a great night.
Thank you. Have a good night, everyone.
Bye bye.